Hi, this is Kellie Edens. Each year, the American Cancer Society publishes statistics regarding their projections for the number of new cancer cases and the number of cancer deaths. For the year 2014, the American Cancer Society estimates that lung cancer is the third most common type of cancer diagnosis. It is estimated that 224,210 new lung cancer diagnoses will occur in 2014. When we look at cancer deaths, lung cancer is the number one cause of cancer-related deaths, with 159,260 deaths in 2014, making up 27% of cancer deaths occurring as a result of lung cancer. This statistical data encourages us to look at lung cancer closely to see what type of preventative strategies can be incorporated to aid in early detection of lung cancer. According to a study by Vellante, Jing, Abrams, and Pison, lung cancer survival is directly linked to the stage at the time of diagnosis. Patients who are diagnosed at an early stage have an improved 5-year survival when compared to patients diagnosed at a later stage. 5-year survival for patients diagnosed with localized disease, 52%. 5-year survival for patients diagnosed with regional disease, 24%. 5-year survival for patients diagnosed with metastasis, 4%. Unfortunately, only about 15% of lung cancers are diagnosed at a localized stage when survival is best. Approximately 85% of lung cancers diagnosed in the United States is the result of cigarette smoking. Although this carcinogen is easily identifiable, there's still a great risk of developing lung cancer even after smoking cessation. Approximately 37% of adults in the United States are current or former smokers. The United States Preventative Task Force is a committee tasked with making decisions regarding recommendations for preventative services to patients. They found substantial evidence that an annual screening tool for lung cancer is needed to identify high-risk individuals and to directly decrease the number of lung cancer-related deaths. Most of the evidence they collected came from the National Lung Screening Trial conducted between the years of 2002 and 2004 in 33 sites in the United States. The study randomly assigned 26,722 individuals to either an annual low-dose CT scan or to an annual chest X-ray. The high-risk individuals had to meet certain criteria. That criteria included individuals who either had a smoking pack history of 20 years, who was a current smoker, or who had quit within the past 15 years, and who was aged 55 to 74. The conclusion of the study was a reduction in lung cancer mortality in the high-risk individuals who were randomly assigned to the low-dose CT scan. The current burden of lung cancer diagnosis and treatment is huge in the primary and oncology care settings. Currently, lung cancer diagnosis and treatment is complex. It increases the total number of healthcare costs, and it impacts the delivery of care. The idea of a screening strategy can greatly improve current practice in cancer care. After the National Lung Screening Trial concluded their research, the U.S. Preventative Task Force revised their recommendations to lung cancer screenings. Now, organizations must review their own policies to incorporate the change and to help improve outcomes and provide early detection strategies for high-risk individuals. This change in policy will be led by the servant leadership theory. A leader who is led by this theory is one who respects, values, and motivates those who follow them. The concern for others and for their health is what motivated this research. The task at hand now is for healthcare systems and providers to work closely together to collaborate and share ideas. Servant leadership ultimately shows commitment to the community. That specific commitment is the realization that poor patient outcomes are associated with current cancer diagnosis methods. Implementation of screenings puts the concept of caring back into nursing and emphasizes the importance of high-quality nursing care, which are both standards of the servant leadership theory. The proposed change would be to implement annual low-dose CT screenings to individuals who are high risk, with the main focus being at the clinic setting, where family practice physicians would be able to identify risk factors. However, another important aspect of this change is going to be to incorporate individualized plans of care. Going forward with this new recommendation, then, requires the complex adaptive systems theory to lead the change. This complex adaptive system theory involves the interaction between chaos and complexity. An organizational structure led by this change has the ability to understand the complex environment and provides the ability to be creative and flexible and to develop relationships. Statistical averages do not allow to identify diversity within a group. Unfortunately, one cannot even begin to group cancer patients into a whole, particularly lung cancer patients. Clinicians must be able to see individual risk factors for the development of lung cancer based upon that individual person's history to develop an individualized plan of care. For example, some patients may not fall under the prescribed high-risk criteria, such as a patient who has worked in a plant. They may not meet the proposed high-risk criteria, but they may also be able to benefit from the annual CT scans as part of preventative services and early detection. Also, it has been identified that smoking is a known carcinogen. Therefore, the complex adaptive systems theory is going to allow us to look at patients as an individual and to care for them according to their own risk factors. This theory is going to lay the foundation for learning more about the complex health problem affecting so many individuals in the U.S. These early screenings will help identify lung cancer in its early stage, utilizing a safe and cost-effective tool. These screenings will limit the invasive procedures, costly treatment, and expensive follow-up studies that are associated with diagnosis at a later stage. Data suggests that diagnosing lung cancer at an early stage increases the 5-year survival rate by a significant percentage. Although these screening tools are not a substitute for smoking cessation, identifying those high-risk individuals can enhance the ability to target early detection strategies. The overall goal of annual screenings is to improve care, decrease cost, and expand the survival rate. All of this is based upon the fundamental value of caring, which is the basis of servant leadership.